Okay, next slide, please. So welcome again, everyone. Today, we're hosting the second webinar in the fourth trimester webinar series, and we'll be focusing on promoting birth equity in the Healthy Start community. Next slide, please. So we'll go over some brief housekeeping and a welcome, and then we'll hear from our presenters, Anis Mahdi and Phoebe Westcott from the National Birth Equity Collaborative. We'll have some time at the end for questions and a short closing and survey. So now I'll hand it over to my colleague, Lisa, for housekeeping.
Thank you, Olivia, and welcome everybody. So just a quick housekeeping before we get started. First of all, this session is being recorded and will be posted on the EPIC website for future viewing. All participants are muted upon entry, and we ask that you remain muted to limit background noise. We encourage the use of the chat box to ask questions or post comments. All questions will be captured from the chat box and we'll address as many as we can. Next, for audio, if you can hear me, you're likely connected correctly, but we'll do a quick review. After you join the meeting by clicking the meeting link, an audio conference box may appear. You can join by either computer audio or phone. To join by computer audio, click computer audio and you should be all set. To join by phone, dial the given number, enter the meeting ID and press pound. Then enter your given participant ID and press pound. You will then be connected to this session's audio via phone. Lastly, to access the chat box, click on the chat button in the toolbar at the bottom of your Zoom screen. A sidebar will appear to the right. Type your questions or comments into the chat box and send them to everyone. Again, we encourage the use of the chat box for any questions or comments during this session. And that is all for housekeeping today. I will now turn it back to Olivia. Thank you.
Thank you, Lisa. Next slide, please. So just wanted to remind everyone that this is the second webinar in this three-part series. If you missed the first webinar, the recording is posted on the EPIC website, and we will put the link to that recording in the chat shortly. That webinar featured the team at UNC's Maternal Health Learning and Innovation Center. And the third webinar will feature that team as well as the team with us today from the National Birth Equity Collaborative. And that webinar will be hosted on August 17th from 2:30 to 4 p.m. Eastern Time. Next slide, please. So now I'm really excited to hand it over to our wonderful speakers today, Anis Mahdi and Phoebe Westcott from the National Birth Equity Collaborative. We can switch over to their slides now.
Thank you so much. I'm just going to pull this up to present. All right, and can everyone see my screen? Excellent. So I wanted to say thank you so much for everyone being able to join us today. My name is Phoebe Westcott. I am a senior birth equity analyst here at National Birth Equity Collaborative, and I am joined by the amazing, the amazing Anis Mahdi, and she, I'm sure, will happily give a quick intro herself, and then we will get started.
Hey everyone, so glad to be here with you all. My name is Anis Mahdi. I am the National Director of Training and Evaluation at NBEC. And even though I can't see you, I think some of you have seen me before or seen Phoebe and I before in some other orientation. A couple months ago, we gave a presentation about CAN advocacy, and I believe some of you were participants on that presentation. We're really excited about talking to you all about fourth trimester work, how you can bring some of this advocacy approach to generate change for your population. So Phoebe's going to get us started, and then I'll pop in a little bit later with some additional strategies for you all to use. Looking forward to your feedback at the end.
All right, guys. So we just want to go over a quick bit of objectives for today. We want to discuss with you birth equity foundational themes, discussing strategies for advocacy and policy change, as well as power and system policies that may impede birth equity, as well as spotlighting a fantastic Healthy Start program and outlining system barriers to birth equity and fourth trimester access. So here at MBEC, our mission is to create global strategies that optimize Black maternal health, infant, sexual, and reproductive well-being. We shift systems and culture through training, research, technical assistance, policy, advocacy, and community-centered collaboration, with the goal of reducing Black infant mortality by 50% in the next 10 years. And our vision is that all Black mamas and babies and their villages thrive. So just getting into MBEC's focus, we wanted to let you know that we see the intersection between clinical and social. And we want to dismantle those systems of power and racism and educate on social determinants of health. And just to go over some of the definitions, one coined by our founder and president, Dr. Joy Perry, is birth equity, something that we really want to harp on today and go into different strategies in order to help you all achieve those goals of birth equity. MBEC wants to position Black mothers and babies at the center of the national reproductive health crisis, and co-creating local, state, and federal policy informed by and for Black mothers helps to achieve this assurance of the conditions of optimal births for all people, with a willingness to address racial and social inequities in a sustained effort. And looking here, pregnancy well-being, sorry, I didn't adjust. Looking here at pregnancy well-being, understanding that we are rooted in reproductive, just apologies, 1 second. Is it showing up for everyone else?
We can see it, Phoebe.
Yep.
You can see it? It kind of froze on my screen as birth equity. Okay, apologies. So definitely looking at pregnancy well-being, we're rooted in reproductive justice, asserting that regardless of access to knowledge, power, or wealth, all birthing people are supported by the government and health systems to physically and mentally be well through their pregnancy. And reproductive well-being. All people have the information, services, and support they need to have control over their bodies and to make their own decisions related to sexuality and reproduction throughout their lives. And we normally share this timeline of the Black experience just to look at some of the experiences of folks who are oppressed in this country over the years. And although this timeline should even go back further than 1619, we're looking at 86% of the Black experience through explicit racial oppression. And then if you look through the entire timeline, 100% of the US Black experience has been in a struggle for humanity and equality. And then taking a glance at human rights, we just wanted to touch on the global standard because we want to see that everyone is entitled to the rights and freedoms set forth in the Declaration without any kind of distinction, such as race, color, sex, language, or religion, or political or other national or social origin. And everyone has the right to life, and everyone has the right to a standard of living adequate for health and well-being for themselves and their family. And one of our foundations is reproductive justice. And Loretta Ross said it best, that the human right to maintain personal bodily autonomy, to have children, not have children, and to parent the children that we have in safe, sustainable communities is something that we all should have access to. And in order to do that, we have to all work together to analyze those power systems, addressing those intersecting oppressions, and centering the most marginalized groups. And join together across these issues and identities to work together to make sure that everyone receives this care. And I love this slide because a lot of folks use these words interchangeably or use one or the other and say this is how they're going to attack these issues. But just to take a look, understanding that the indicators don't equal a framework. The indicator is a data point, so something that you're measuring. Measurement limited by an actual reality, something that's currently happening. It's a product of past understanding of public health and science. And then just to look at framework. A framework is a vision and understanding what's really happening right here, right now. And it allows folks the freedom to explore the different indicators that they have before them to make a different reality for the future. And then just to take a look back, I was so excited to see your answers from the questions when you registered. I noted that several of you had answered in terms of benchmarks, how your Healthy Start program is doing. There were mixed responses of not meeting the benchmark, don't know, we're exceeding expectations, which, I mean, it's completely understandable because each program is starting at a different place. And then looking at your 3 top concerns, just to touch on a few to understand like maybe some of the things that we're going to go into and some of the strategies that we're going to provide today. Some of your concerns were engagement, postpartum visits, support services, and COVID. And then some of the items that you answered towards support that you would need to better serve your community would be improvement ideas, realistic and reliable resources, and training. So throughout today's presentation, we're definitely going to touch on a lot of these topics and more, and hopefully answer some of these questions and concerns that you may have. And so just to go into, apologies, the social determinants of health, let's look at the root causes of the social determinants of health. And we'll think about what's led to our current state of maternal and infant health. So depending on what training or background that you're coming from, you may be more or less familiar with the concepts of social determinants of health. And so this is an important public health practice because it helps us understand why people and communities may struggle more in order to stay in good health. And it also helps us to see the big picture and to understand the patterns of health and disease across different populations, as well as thinking about holistic solutions that can help these communities thrive. And another favorite public health model is the socio-ecological model. And so we like to look at this and think of it as a framework in this case. And it can be a framework for preventing birth equity. And just looking at these 5 levels, you have the individual, so knowledge, attitudes, and skills, interpersonal, family, friends, social networks, organizational, of course, organizations, the community, those relationships with different organizations, and public policy, so those local, state, and federal laws. These 5 levels help us understand the range of harmful and protective factors that your clients may experience. And it also helps you see that in order to improve birth equity within your organization, as well as across the country, you have to act across these levels at the same time. And so as we move throughout this presentation, to take some time to think about what are some systems and structures that are currently inhibiting birth equity for you. So before we move into the social construction of race, I wanted to take a quick look at racism, because we think that this is definitely, and we know, not think, we know that this is a part of the social determinants of health because it affects health both directly and indirectly. Directly via chronic stress, and indirectly it can be race-based discrimination across different systems, as well as access to education, high quality education, safe neighborhoods, quality healthcare. And so this is also another way that shapes, another item that shapes the way your clients access their health. And so in order to look at race and racism a little bit more, I'm going to turn it over to Ms. Ines Madi for further information.
Thanks, Phoebe. I love that. Let's just look at race for a second, just a quick second. Hey, everybody, I hope you're still with us. We've got some interesting things to kind of dive into. Phoebe set us up by talking about the social ecological model and the different levels that impact your clients' access to health and ultimately their maternal and infant health outcomes. I'm going to talk now a little bit about the social construction of race, just to follow up on Phoebe's point about racism as a social and structural determinant of health. Next slide, Phoebe. So if you see me talk before, you might have seen this slide before. Oftentimes what we see in our society is a conflation of different terms. We say that race, it's essentially an ethnic group, or it's a population, or it relates to ancestry. But what I like to say is that race essentially is how we do racism, right? Why does racism exist? It's because we've created these categories of race. So they are not solely ethnic groups or populations or ancestries. It is about the way that we assign privilege and rights throughout our society, right? So this slide says race is real, but it's not real in the way that racists think it's real. It's not a genetic cluster or population. It's not biological, but racism can have biological effects. So sometimes when we talk about race in some of our trainings, we have a slide where we ask folks to kind of define race. What is race to you? And a lot of times what we get is a social construct, a social construct. Lots of folks know that this is kind of a phrase that we're using all throughout society. But what exactly does that mean? What does a social construct mean? And what does that mean for our clients every day? What does that mean for us? What does that mean for providers? What does that mean for systems? So that's what we're going to talk a little bit about now. Next slide, Phoebe. So I've kind of hinted to this. It's racism and not race that we're looking at. So oftentimes we see our data aggregated by race, but what we're really looking at is the impact of racism. So what Phoebe's got up now is a slide from Kamara P. Jones, esteemed researcher who kind of put a lot of the seminal research out here on the levels of racism. And she talks about institutional racism, she talks about internalized racism, and she also talks about personally mediated racism, all of which are super important for thinking about the impact on our health and the health of our clients. Next slide. So institutionalized racism represents the structures, policies, practices, and norms resulting in differential access to goods, services, and opportunities of societies by race. So I like to think of this as kind of like racism, big R, big R racism, our big kind of umbrella where everything else falls underneath. This is, although it is the big R, it's also the one that is most invisible for folks to understand because it is a set of structures and systems that work in tandem with each other that either restrict or give access to services and goods and other opportunities, significant opportunities by race. The second level of racism is what we call personally mediated racism. And that is what most people think about when they think of racism. They think, oh, it's a person who's using some racist graffiti on the side of your house, burning crosses. We think about this in terms of biases and differential assumptions, actions, intentions by others. This is the kind of racism that folks most often think about. And then the last level of racism, according to Kamara Jones, is internalized racism. And that is the acceptance and entitlement of negative messages by stigmatized people and non-stigmatized people. So an example of that is, let's just say we have students who are in school and are being told consistently, oh, X group is not good at math. And then the student begins to internalize that message. Or X group is good at math, and that group begins to internalize that message, right? So there are multiple levels at which racism surrounds us. And I can't remember who it was that said it, but essentially it's that racism is we are fish and racism is the water that we swim in. It is all around us. Some of it gets inside of us. We see through it. Everything comes through that lens because of essentially institutionalized racism and the way that our country was established and continues to run today. Next slide. So in terms of finding the roots of inequities, just to kind of bring it back, the whole point is, why are we having disparities? Why are we seeing differences in health outcomes? So this slide just kind of goes through a couple of quick tidbits on some data and the way that data is presented that leaves us questioning what are the roots of these inequities. So the first point there says, Black mothers who are college educated fare worse than women of all other races who never finish high school. Obese women of all races have better birth outcomes than Black women who are of normal weight. Black women in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poorest ones. And finally, Black women who initiated prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. So data is not often put together in this way, but if we take these extracts, right, and we put them all together, what is this telling us? This tells us that there's something else happening here. It is not simply being Black that makes you have a poor outcome. There are other indicators that are associated with Blackness or associated with Hispanic identity that are coming into play here. Next slide. So, in trying to look at what those factors are, this IMBEC developed the Birth Equity Index, and I know it's hard to read, and I hate when people put up a slide and say it's hard to read when you know it's hard to read. This is made for publication, but I'd like to talk about it in our presentations because it's super important to look at. So what you're looking at here is by city. So on the left-hand side of this, the left-hand side of the white part of this slide are metropolitan areas, right? And so what INMAC did was they gathered a composite, or they created a composite measures based on structural and social determinants of health, right? And looked at how those clustering of those social determinants of health were related to infant mortality, right? So those that are in blue and those are turning more so towards the left shows that there's a correlation with certain structural determinants of health, better green access, lower homicide rates, less smoking, less obesity, that those clusterings of indicators were associated with improved infant outcomes. And those on the top of the screen on the right-hand side where they're red that are shifted towards the right had poorer birth equity outcomes in terms of infant mortality. And those were all clustered around those higher concentration of poor social determinants of health. So if you look at this, and I think this is something that we kind of all know inherently, that where you've got kind of a better set of social structures and systems in place, then you're going to have better outcomes, right? Okay, let's go to the next slide. So this is just showing you how the clustering of infant mortality looks for individuals identifying as Black or African American, right? And you'll see those higher concentrations, the darker colors for African Americans, of course, across the South and into the Midwest. Okay, next slide. We're going to look at this. Same data, infant mortality by white identity, right? And so we see a little bit fewer of those darker shaded areas, but still ultimately infant mortality is still also a problem. So I think one thing that is easy to misconstrue is that poor social determinants of health only impact Blacks or only impact those of Hispanic identities. And in fact, they're impacting all individuals who are living in those areas, right? Impacting those individuals living in those areas. But we also have to look back at our policies and structures that indicate where individuals can live, right? Next slide. So these two we're focusing on infant mortality. So now we look at maternal mortality and we see the trending rates there, and we look at comparisons between individuals who are Black, white, or Hispanic. And you see since 2001, and this slide is a little bit outdated now. I think we've got data up to 2018, but you see that there is a steady increase in infant mortality over time. While there's an increase overall for most of the groups, the steepest rise here appears to be among Black individuals. So we're not only dealing with infant mortality crises, we're also dealing with maternal mortality crises, right? Which is where you all come in. And we're so thankful to be here in community with you all as we talk about strategies to address these. Next slide. So a lot of times, depending on the spaces that we're in, we have folks who want to talk a lot about clinical risk factors, particularly for maternal mortality. And I imagine the same for infant mortality. This slide focuses on maternal mortality. And so there's a lot of talk about how our moms are presenting. Oh, our moms have got eclampsia, our moms have got high blood pressure, oh, their BMI is too high, they've got other heart issues and things. And so that really points the finger at the mom. And we say, you know, stop blaming moms for dying when we have failed to look at everything else that comes on the right-hand side. So on the right-hand side, and I know Phoebe said at the beginning, MBEC tries to look at a merger of clinical and social risk factors. So on the social side, we've got housing, right? We've got income inequality. We've got safety of neighborhoods. What's the air quality look like? What are environmental stressors? Food insecurity. I'm not going to read them all to you all. You all can look at this and you know what's happening in your populations and the groups that you're serving. So we just ask that there be a balanced approach to looking at what are the risk factors that are impacting the broader group. Yes, we'll have some of our moms present with eclampsia, but have we even considered what's happening in the environment? Have we considered food insecurity? Have we looked at generationally, right, how these things are building up and presenting in our population? And fortunately, I feel like we're getting to the point where we're at a crossroads where people are beginning to look at and start to kind of crawl their way towards disrupting and dismantling these structural determinants of health. Okay, next slide. So in terms of doing that, we're just going to talk a little bit about some policies around perinatal health that can be supportive. Next slide, Phoebe. So I know I mentioned earlier, just talking about infant mortality. This slide really just kind of talks briefly about some efforts that began, I believe, in 2016 to address infant mortality, which is the campaign for Black babies that was located in the cities that you see here highlighted. And also MBEC also undertook some research looking at what were the perspectives of moms who had suffered an infant loss. Right? What were their lived experiences? What was their treatment like in hospitals? What were their community connections like? Where were their gaps in the system? What were the things that went unaddressed? What were the assumptions that were made about Black moms when they lost a baby? Was it that, hey, you probably didn't want that baby anyway? Was it that, you know, hey, we're going to make sure that you have support? Were the maternal mental health services supportive of what women were going through? So that was kind of an offshoot of this project. So really trying to look at what are the gaps so that we can hold the system accountable for addressing those, particularly as it relates to Black infant mortality. Next slide. So we know that power imbalances create racist policies. So their racism is essentially, it's a system of power. Who has power to decide who has what opportunities, whose opportunities are restricted? So we know that racist policies come from power imbalances, and that racist policies create health disparities or inequities. And this is, it seems like sometimes it's a very, very heavy lift to try to undo every single thing that has been done. We did not get to this point overnight, and we're not going to change it overnight, right? But we also know that past political action can be undone if we are deliberate and intentional with our current political action. And there's a quote down here at the bottom that says, racially discriminatory policies have usually sprung from economic, political, and cultural self-interests, and those self-interests are constantly changing. Politicians who were seeking higher office have primarily defended and created discriminatory policies out of political self-interest. Capitalists seeking to increase their profit margins have created and defended discriminatory policies out of economic self-interest, right? Not necessarily racist ideas. And cultural professionals like theologians, artists, scholars, journalists, researchers who are seeking to advance their careers have created and defended discriminatory policies because of their own professional self-interest, not racist ideas. So if we keep in mind that there are self-interests, right, that folks want to protect, that maintain these power imbalances, we can be free to do the work and understand that everyone has an angle that they are approaching these things with, and we have to understand that very well if we want to advocate for our populations. Okay, next slide. So, well, let me just ask Phoebe, how are we doing on time?
You are good. You are a whole, let me see, 3 slides ahead of schedule.
Hey, okay, great. You all let me know if I'm talking too fast. I get really excited about talking about racism. So if I go too fast, just, I think down at the bottom, you can hit the reaction button. You can raise your hand. Oh no, you can hit an arrow that says slower or faster. So I will check the box and look for your feedback if I'm going too fast. I want to make sure that we have plenty of time for Peggy Vandermeulen, who's going to give a presentation on some of the work of her Healthy Start committee or her Healthy Start group, and it's fantastic. So I want to make sure you've got plenty of time for that. So, okay, hopping back to history of reproductive injustice. So we're talking about this self-interest, right? And how this self-interest drives our policies. This slide just kind of talks about what the history of that has been with regard to reproductive injustice. So Black women's bodies were used as vessels for the institution of slavery in the United States. That is primarily to reproduce capital for slave owners and for societies to build a lot of the structures that we have around us today. There's also experimentation on Black female slaves that ultimately led to a lot of the technologies that we have in modern day gynecology. Dr. Samuel Cartwright's drapetomania research was facilitated and supported by Tulane University, right? And if you're not familiar with drapetomania was Dr. Cartwright's assertion that it was a disease of Black people to want to run away, a disease of enslaved folks to want to run away and to want to be free, when naturally they should want to be enslaved. And so this research was funded and propagated by our university systems, right? And so there's so many different hands in this racism big R that are that we really have to pull back and look at. This is not solely one person in a cape, one person waving a swastika. This is a societal, a structural system that held a lot of these policies in place that we're just going to have to disrupt because we see the impacts on those things today. Black women were forced to feed and care for and breastfeed white babies, which of course impacted their relationship and their ability to be able to breastfeed their own babies. We also had eugenics and systemic manipulation of Black family planning, lots of sterilization efforts once Black women were not actively producing capital for society to benefit from. So there's so much in our history that impacts where we are today. So hopefully this doesn't seem too far off from what we're here to talk about today, but the impact on how folks are accessing services. What does it look like to go back for a visit after labor? What does it look like to not be traumatized in a system? What does it look like when the hospital healthcare system and community systems do not talk to each other? How does it feel to be bounced around from one place to another? And what are the legacies of injustice that we're still dealing with today? Those are the things that are going to have to be corrected in order for us to get to the outcomes that we are looking for. Next slide. So in terms of another thing to be corrected, I don't want to harp on this. This really is a bright and sunny presentation at the end. Just a quick view of Black midwives as an example that were seminal in delivering babies in the Black community, were essentially outlawed, driven out of practice by white male OBGYNs, propagated smear campaigns, forced to undergo like so much additional training and certification after they had been practicing for years and had not lost babies. There are so many things and so many systems and policies that were put in place to essentially annihilate this workforce. And in our communities, we still see the impact and the ramifications of institutional policies, state and federal dollars on whether or not we have practicing midwives around the country right now. I think the last count, there were maybe 50 Black midwives, when there have been hundreds and hundreds prior to the turn of the century. So just a quick snapshot example of how policies can impede maternal health and how they can impede infant health. Because we saw that when we transitioned from giving birth at home, when we transitioned from the use of midwives, even in facilities, to male physicians, and in hospital births, we didn't have a major decline in maternal mortality in the African American community. So this is an annihilation without furthering for better outcomes, but all driven by policy, all driven by structures. All right, so this is just kind of coming back to our previous slide. So there is a lot of talk, or at least has been the predominant talk, and my training is in public health and epidemiology, has been primarily on what is individual accountability, right? How can women put themselves in better positions to have better outcomes? What does that look like? But ultimately, we have to remember that there is collective accountability, as that none of us are, or they say no man is an island. We did not just spring up here, right, and create our own every single one of our own outcomes. We have to look collectively at how systems are lockstep with the poor outcomes that we see. Okay, next slide, Phoebe, and then I'm going to get ready to turn it back over to you. So just a quick example for COVID-19. I know some of you included COVID-19 as other fears and concerns that you had regarding the health of your clients. And we're still seeing inequities in our COVID-19 presentation, survival, and number of cases, and also in deaths. So we know that our pre-existing structural determinants of health were healthcare access, right? We know that proximity to hospitals with high quality care, having multi-generational households living together, right? Where you've got grandmother, you've got breadwinner, you've got children, you've got uncle, you've got aunt, because of restrictive housing policies and housing discrimination, right? We've got pre-existing conditions, heart disease, diabetes, asthma, obesity, COPD, which are all related to our environmental conditions, right? So it seemed like when we started to get a lot of this data very early on in the pandemic, folks were surprised that we were seeing inequities there. But ultimately, this is the background from which COVID-19 acts. This is a background for which your clients are going to be trying to seek services, right? So how do we address that? How do we make sure that we have the data that we can report a very accurate picture on what's happening? And even in some states, they still have not necessarily disaggregated their data by race and ethnicity because, well, I'll leave that for you all to speculate. But we can't begin to drill down to a problem until we're actually looking at the data that tells us exactly what the problem is. So I think that's it for most of the bad news. If you started to feel down, Phoebe is going to take us out. She's going to start talking to us a little bit about strategies, and Peggy is going to share with us a little bit later some of the amazing things that they are doing there to address some of the issues that we bring up here. So with that, Phoebe, I'll turn it back over to you.
All right, thank you so much, Inas. Yes, like she said, we're going to go over a few quick strategies to help you move forward. And just like Inas was relating to earlier, looking at using a racial equity lens, but using the racial equity lens, we want to understand that this health system was built as a racist institution, but it took a long time to get there, and it's not going to be, undone overnight. So using the racial equity lens, we want to center places, environment, and social determinants. We want to address those aggravated risks for specific local challenges and address those intergenerational and cumulative effects of structural racism. So looking at centering the place, the environment, and social determinants, you want to gather the data on your participants or your clients through community partnerships, for example, FEMA. You should also conduct advocacy programming for social determinants of health. When addressing those aggregated risks for specific local challenges, you want to actively address the local social determinants of health that are affecting your clients. And when looking at intergenerational and cumulative effects of structural racism, you want to think about the funding for expanding programming, like participant incentives, increase the rigor in your evaluation efforts of programming, and also think about support for shared decision-making. So how would you use those participant incentives to conduct focus groups or get those folks to join you in creating the next steps to expand your programming? And so I know you've seen this a lot. It's a fantastic buzzword, but we really think that this strategy is an excellent resource. Data, data, data. Data can help you tap into so many helpful ideas on how to uplift your programming, create better programming, improve upon your access, your reach into the community. It can help you identify how well your system is giving those moms and babies a healthy start. Such data can identify the effects of the health environment, which could include factors like the quality access to medical care, access to sound nutrition, and as some as you mentioned as your concern for folks in your program, transportation. And one source of data I think that could significantly improve upon how you focus on your services in the community is the community themselves, the people that you serve. And let's take a look at one way we're currently gathering that type of data. So in 2019, HRSA awarded the National Healthy Start Association with a 5-year award for a project that focuses on improving maternal health outcomes. That is called the Alliance for Innovation on Maternal Health and Community Care Initiative. And their goal was to reduce, or is to reduce, maternal mortality and morbidity through the development and implementation of non-hospital focused maternal safety bundles in the communities and outpatient settings. And currently, MBEC has partnered with AIMS CCI in order to conduct community focus groups to make across these 8 pilot sites that are participating in this project, to speak with those participants. And we want to look at their experiences before and after these non-hospital focused maternal safety bundles have been implemented in these communities. And so it'll help these different sites improve upon their initiatives and the connection building that they're trying to seek within the community and the healthcare systems. And just to take a quick look at the pilot sites that are currently participating, we have Atlanta, Georgia, the Center for Black Women's Wellness, Grand Rapids, Michigan, which you'll hear from Peggy shortly, from Strong Beginnings. We have New Orleans, Louisiana, with the New Orleans Health Department, Fresno, California, the California Health Collaborative, Jackson, Mississippi, the Jackson Hines Comprehensive Health Center, and Tulsa, Oklahoma, the Community Service Council in Tulsa, Oklahoma. And so just to touch on an excellent program that is really making headway in these efforts, I'm going to turn it over to the lead organization in Strong Beginnings with Miss Peggy Vander Meulen. Peggy? And I'm going to stop sharing so that we can switch out.
Peggy, you're still on mute. And we want to hear everything you have to say.
Oh my goodness.
There you go.
Think I would have learned by now. Oh, so sorry. I was just saying thanks so much for having me. And it's so nice to see several old familiar faces among the participants. Next slide, please. So I'm just going to share briefly a little bit what we do specifically around the 4th trimester, not our entire program, just related to postpartum and primary care, some of our outcomes and some of the things that we've learned along the way. Next slide. So we are, as Phoebe mentioned, a federal Healthy Start project. As all of you working to improve maternal, and child health, our focus is specifically among African Americans and Latinx. With father engagement, with the ultimate goal of eliminating racial disparities in health status and birth outcomes. By the way, we also have several projects that focus on immigrant and refugee families from countries in Africa. Next slide. So we're basically a partnership of every major healthcare institution in Kent County, the 3 healthcare systems, our mental health provider, evaluators, our FQHC, CBO, and Spectrum Health serves as our fiduciary. Next slide. So I was asked to share, so we do a lot of work, I will admit, and we do this because we have additional staff and additional funding besides the Healthy Start Fund that you'll see in a minute that allows us to do this expanded work. So you see we have basically a total of 50 health staff. 6 of those are with the Baby Scholars, which is kind of a parallel program we have. It's a parent education and child development program. Predominantly community health workers, 2 of whom are male. And next slide, please. These are the funding streams we currently have. So for Healthy Start, it's roughly around $3.3 million a year. This varies. For example, this year we're losing 2 of those funding streams. But yes, we do have other investors. And part of this funding we've been able to obtain because we leverage past successes in order to obtain additional funding to expand our work. Next slide. So then, as I mentioned, we work with Latinx and African American birthing persons. as well as refugees and immigrants from African countries through pregnancy, parenting a young child, and who are Medicaid eligible. We also enrolled all children under 18 months of age and partners of our program participants. So we serve roughly 1,000 families every year. Last year, we had over 1,700 unique clients. Next slide. So these are objectives related specifically to fourth trimester. So again, trying to increase postpartum visits, access to mental health, father engagement, promote a good child spacing, improve breastfeeding rates and duration. Next slide. Access to medical home, provide education to community members and healthcare providers, and to raise awareness about the effects of the different levels of racism, individual, structural, and internalized, on health disparities, and to promote health equity, and work locally to improve the overall system of care for everyone, not just our clients. Next slide. Like all Healthy Start projects, we work at 2 levels. One is direct services to the enrolled clients. And then again at the systems level, whether it's through our Community Action Network, which for us is the Infant Health Action Team, by coordinating with local, state, and national entities that work on maternal child health and equity. And again, underlying everything and through everything is to promote health equity. Next slide. So one of our very core and our key component that I credit with our success is our community health workers. So they conduct outreach, for example, well, pre-COVID and post-COVID, they're out in the community, pounding the pavements, visiting nail salons, schools, cell phone places, grocery stores, family planning testing centers, etc. But more importantly, and they provide ongoing home visits and support to their clients with caseloads of 30 to 35 clients each. Now in Michigan, we have the Maternal Infant Health Program, MIHP, which is funded by state Medicaid dollars, where nurses and social workers provide up to 9 home visits during pregnancy and 9 visits during infancy. This is a MICV evidence-based program. So what we do is we serve as an add-on to MIHP. We add our community health workers certified. They go through a 3-month certification course, extensive training on everything from infant CPR to motivational interviewing to family planning, you name it, breastfeeding peer counselors, certified lactation consultants. So they form part of that MIHP team. Then they work together with their clients. Again, they have much smaller caseloads than MIHP coordinators, and there's no limit on the number of visits they can do. So they help develop goals, they provide social support, health education, and then connect them to whatever services are needed, whether it's housing, completing a GED, career development, transportation, employment, and so on. So for example, we have agreements with 5 different employers that they will provide priority employment to our clients and guarantee them a livable wage. Next slide. We also have a companion mental health program. So we have our own contracted therapists, 4 therapists, African-American, Latina, who again provide individual counseling, group sessions. They're trauma-informed certified center. They, as well as our community health workers, also offer ROSE, which is an evidence-based postpartum depression prevention program. They also have therapeutic support groups, and they often do joint visits with our community health workers, have that warm handoff. They provide support to our staff as well as education for us and for providers. Next slide. Our fatherhood program, again, we have male, African-American, Latino community health workers that provide parallel services for the male partners of our of our clients. We also have group discussions, father-child activities. Coming up next month, we have a flag football event. They do a texting program and do lots of workshops and presentations, both for providers and for community men. We also have arranged with Friend of the Court, where every month, anywhere from 3 to 10 men we provide alternatives to their serving jail time. So they're able to remain with their families and support their children rather than serving jail time. Next slide. We have our community educator who does extensive community education related to maternal, paternal, and child health. We have weekly breastfeeding support groups. We do a lot with ICE because so many of our clients are impacted by ICE detentions and deportation. So knowing their rights, how to prepare for possible deportation. A lot of our education is focused on racial equity and implicit bias. Next slide. And the reason for that, as was demonstrated extensively in Ina's presentation, is that racism, compounded by the growing gaps in the United States in wealth and income, that racism is the root cause of the health disparities, including disparities in birth outcomes and maternal health and mortality. Next slide. So what we're doing, specifically with the AIM-CCI pilot work that Ina mentioned. So what we're doing, you're probably familiar with some of the clinical AIM bundles that ACOG developed back in around 2015. So some of those were very clinical standard procedures on what to do, for example, within the hospital in case of a hemorrhage, of eclampsia, of sepsis, and so on. So what we're doing is taking the concept of those bundles and translating them into use at the community level, because we know that women's health depends on far more than what happens inside those 4 hospital walls. So looking at both community clinics and community-based organizations to implement and test several elements of each of these bundles. So starting with the postpartum bundle, which is addressing the transition of women from prenatal care to postpartum and primary care. So there are close to around 20 elements in this bundle. So we did extensive evaluations, and that's a whole other story. That's another hour presentation. But anyway, we landed on these elements as the key ones we wanted to focus on initially this year. So we'll talk about each one of them in the next few slides, what we're doing on each of them. So next slide, please. So one thing was to educate birthing persons, their friends and family on the warning signs. So we looked at all the tools and resources we could find that were out there. And our group here locally thought that the CDC's Hear Her campaign was the best one for our community. And it truly is amazing. If you have a chance, just go to the website and check it out. A wonderful array of tools in 17 languages. All sorts of materials. There's a QR code for quick access to it. So they have tools to help increase awareness of what these warning signs are. They empower women to speak up and shout out their concerns, and for their support systems also to recognize these symptoms and to support her in accessing care. Basically to help women and providers to better engage in communication and conversations. Next slide. So what we're doing so far is in Kent County, all of the MHP care coordinators have already adopted this as part of their action plan. And there is interest at the state level, if all goes well here, that they would adopt this Hear Her intervention as part of their statewide plan of care. And MHP statewide reaches 44,000 women a year. We've also added the Hear Her interventions to our community health worker interventions. We have brought on hospital inpatient staff, the OB residency clinic, the largest one in the county. I have already incorporated these materials. Our fatherhood program has done Facebook Live sessions and provided education for partners, for friends and family. We've done extensive presentations with our CAN members and other local organizations. We've distributed probably close to 7,000 now QR code stickers that go out to patients and clients. Thousands of printed materials in multiple languages that have gone out throughout the community. Next slide. So that's just an example. So our community health workers have very comprehensive intervention guides around a whole host of domains. So one is during pregnancy, then this is for the first 3 months of the interconception period. So this is just an example of what the community health workers are doing. Anything red is a mandatory intervention that then they document in the database. Next slide. Another tool we've used is our evaluators at Michigan State University, together with our clients and our staff, created what they call Empower Yourself to Be a Healthy Woman toolkit, a 6th grade level in English and Spanish. It's a very, very simple action tool to help women understand why and how to access postpartum and primary care, what to do after hours, when to seek emergency care, when to seek urgent care, and so on. And there's a companion guide for the community health workers to help their clients walk through this transition and make sure they have their plan in place and that they're accessing their care according to their plan. So basically, it really tries to be an empowerment tool to promote shared decision-making and self-management skills. Next slide. As kind of a companion to these, both the Hear Her and the Empowerment Toolkit for women, we're trying to improve communication on the provider side as well. So a lot of that is being done through implicit bias and managing unconscious bias. So not just learning about implicit bias, but over time, again, developing and adopting tools to help rewrite those unconscious scripts. So we have quarterly sessions with OB residents, family practice residents, and so on. And then they're also offered to the community at large. They're mandatory for our staff. I can't even tell you how many thousands of people have gone through these already, along with our 2-day health equity social justice dialogue sessions. Again, these are more modeled after, if you're familiar with People's Institute or Crossroads anti-racism workshops, these are more similar to that, but with a health focus. We also have multiple candid conversations on race and racism, truth and racial healing transformation circles. Anyway, a lot of work on anything related to racism and racial equity. So just an example, last month, I just got our staff report. Last month, we had 334 individuals participating in sessions related to racial equity. Next slide. So another one of the elements that we wanted to test was, one of the elements is worded, maintain an up-to-date list of community resources, sorry. So that's where they actually, several years ago, our CAN with our clients and staff had created several very simple screening tools at a 6th grade level for providers to use. Clients and individuals can use them as well to screen for social determinants of health. Things like, what's your housing situation? What about social support? How is your partner treating you? Do you have enough food to eat? What's your stress level like? Those kinds of things. And then they're connected to these decision trees. So we have 12 of them. This is just one sample on the right side. So somebody in an intimate partner violence situation, if they need shelter, that's where they can go. If they need counseling, that's where they can go. If they need legal assistance, those are the local resources. So those are all available to providers, to the community. And we're in the process of updating them. Again, of course, they need to be updated regularly. So we're almost finished updating them now. Next slide. And actually, what we're hoping is that those updated resources and the screening tools will be used by clinicians as an interactive app Dr. Steve Andersma, Michigan State University, is working with the State Health Department. They've developed, it's called a high-tech, high-touch, or HT2 platform. And it's for clinics to use at the first visit with a woman or birthing person. And it has series of questions that can be determined locally. Again, there's not a set series of questions, but related to all these social determinants of health. If something is triggered like substance use or mental health, they're offered a brief intervention and then offered a resource referral to local resources related to whatever their issue is. So that's where our tools will come in as these referral sites. And we intend to use these through iPads and QR codes. Next slide. Another element was to develop close and formal connections between clinics, clinicians, and community services. So this again is older data. We had used this in the past and we're still using it now. Our evaluators had shown that clinics that had formal processes for referring their patients to our programs, both to Strong Beginnings and to the MIHP programs, had higher rates of, the increased rates of support program participation, first trimester care, adequate prenatal care, and postpartum care, especially for Black women. So we were showing this to the clinicians saying, hey, look, if you refer our patients to us, we will help them complete these services. Next slide, please. So we've been sharing some of our outcomes, our decreases in preterm birth, our increases in breastfeeding, our decreases in rapid repeat pregnancy, and we were accused of cherry picking. So our evaluators did a 3-year quasi-experimental design study, finding that basically our clients were much more likely to be unmarried, in extreme poverty, unwanted pregnancy, abusive relationships, clinical depression, etc. But that these same women had higher rates of postpartum exams, as well as well-child visits and adequate prenatal care and lower rates of preterm birth. So using this as postpartum exams was a critical piece. Next slide, please. A study again, a similar study done, finished in 2019, showed again that we continue to serve women at higher risk, and yet we still have much higher rates of adequate prenatal care, postpartum exams, and lower rates of preterm birth. Next slide. So then this shows here some of the latest data that we have, showing again for I'm sorry, there's the first column, postpartum visit, the second column where it says 56.5% and 90.4%, that should be all Strong Beginnings clients. And the next column over should be all African-American clients in Strong Beginnings. So sorry, that's missing from there, but it's basically comparing them to other Medicaid eligible, Medicaid enrolled women in Michigan. Next slide, please. So another one of our successes has been in decreasing rapid repeat pregnancy. That's a subsequent pregnancy within 18 months of their delivery. So basically this statistical analysis showed that our clients had a 17% rapid repeat pregnancy rate versus, again, depending on how they were counting it, between 25 to 35% for clients, women not in our program. And again, thankfully, this is quite a bit lower than the HRSA benchmark of to be under 30%. Next slide. And we know that rapid repeat is a factor in for further adverse birth outcomes. Again, some related, again, this is just client self-reported data. It's not validated yet by vital records. So we continue to show success in increasing postpartum visits. And keep in mind, this was during COVID. right? This is during COVID, and we had 86% in-person postpartum visits. Medical home, 94%. Again, our well woman visit was down a bit in 2020. Again, we think because of the COVID, but breastfeeding initiation and breastfeeding at 6 months is nowhere near the whatever 61% HRSA benchmark, which I think is completely unrealistic for Healthy Start. So I compare us to WIC clients in Kent County, where slightly over 15% were breastfeeding at 6 months. So I consider this a success. Next slide, please. Another way that we've been successful, these are just some recent examples from the past few months. And of course, we're not claiming we did this on our own. This is all group effort. But for example, Governor Whitmer declared it's mandatory now for all healthcare providers, including even veterinarians, to go through annual implicit bias training in order to maintain their licensure. And our staff were participants on the work group that proposed that measure. There were also on work groups that got the state to extend Medicaid coverage for postpartum persons up to 12 months. This was even before Governor Whitmer's announcement that we got a extremely large hospital system here to require all 32,000 employees to participate in implicit bias and racial equity training over the next 3 years. We've also been successful at obtaining housing, promoting affordable housing, some other issues as well. And we continue our advocacy for community health worker reimbursement and end to ICE detentions and deportations, comprehensive sex education, paid parental leave, affordable childcare, all those other social factors that impact our families' health. Next slide. So some of what we've learned, as I mentioned, our community health workers and kind of working in tandem with our therapists are the key to our success. I mean, they come with lived experience. Several of them are former program participants themselves. So they're able to build those trust relationships to serve as peer mentors. They also serve as a bridge between the community and those large, convoluted, complex healthcare systems. It does help that they have extensive relevant training within their sphere of action, strong support, very clear roles, and that they're recognized as professionals. I know sometimes they're called paraprofessionals or lay persons. We think that they are professionals in their own right and treat them as such. Next slide. Again, you all know this, your Healthy Start. You know that involving community clients from the very beginning in whatever activities you're doing, whether it's planning, developing, testing, implementing, and creating educational materials or tools is critical to their success. Again, reaching out to clinicians, contacting them, being very proactive at reaching out to them, saying, hey, we're here. Here's what we can offer. Look, this is what we can do. This is what we've done. This is how we can help your clients. How can we help you? What would help you? How can we help you connect your clients to our services? What are the easiest ways, the processes? Do you need any special tools, any materials, anything that we can do or create for you? And again, using data is a powerful tool to get them to see the benefit of connecting to programs such as Healthy Start. Again, forming those multi-sectoral partnerships and multidisciplinary teams, such as we have with community health workers, nurses, social workers, therapists, and fatherhood in order to meet holistic needs. Next slide. Again, working at all levels, working at the individual level is wonderful and necessary, but it's not the end all and be all. So again, we need to involve the family, the community as a whole, and again, those larger systems. And of course, unless we are addressing the underlying cause of health disparities, health inequities, we won't make any long-standing change. And I always like to look at this from, I'm not sure if it's Dr. Renee Kennedy or Dr. Arthur James, who frames it this way. So the downstream are the health outcomes, birth outcomes. Midstream are the social determinants of health, and the upstream factor is racism. And as Ina alluded to, or actually said very specifically, she could let collective responsibility. So, you know, personal responsibility is kind of this big thing, and people need to, you know, bootstraps kind of attitude. That doesn't do it. We need to have at least as much a sense of social responsibility as we do towards personal responsibility, and looking at the systems that keep people oppressed, particularly women, LGBTQA, Black, Indigenous persons of color. Next slide. And that's it for me. So thank you.
Right. Thank you so much, Peggy, for joining us and sharing that fantastic story of what your group is doing already. Let me just move back into my side of things. One moment. Okay. There we go.
Thank you, Lisa. Thank you, Benita, for posting that too.
All right. So thank you so much, everyone, for sticking with us. And we're going to breeze through because we see we are getting short on time. But I wanted to quickly go into these next round of slides that's going to go into the big P and little p of policy. So big P thinking federal, and little p looking at local and state. And so for MBEC, we created this birth equity agenda, and it looks at the 5 critical measures for ensuring that the US as a whole has that infrastructure, as well as the resources in place to achieve equitable health outcomes for mothers and babies, birthing people. Apologies. And so just to do a quick overview, MBEC has excuse me, MBEC has endorsed the Momnibus Act of 2021, and it was introduced by the U.S. Representative Lauren Underwood of Illinois and U.S. Senator Cory Booker of New Jersey. And the Momnibus, and I won't read each one on here, you can go through it later on, but it's a comprehensive package of legislation comprised of 12 different bills that address the multitude of factors that are responsible for the unnecessary deaths of Black pregnant people and the near misses, so morbidity, including issues of systemic racism and social risk factors like housing, transportation, and environmental risk. And it also enlightens folks on the core tenets and principles of reproductive justice. And that, my friends, is very foundational to MBEC's work and one of the key drivers of our advocacy efforts. All right, and then healthcare coverage. So I just want to touch on this really quickly. I understand that several of you noted the concern or wanting more support for the continuity of care, or making sure that folks are taken care of prior to the postpartum period, and that they have access to those resources. And looking at the health and well-being of pregnant and parenting folks occurs in the weeks and months postpartum, but we also want to think about maybe let's look at 2 of the different bills of the Momnibus 2021. So just touching on it, maternity care payments, those types of models can always influence moms and babies. So looking at the potential for innovative payment models like improving outcomes on the Centers for Medicare and Medicaid Services. We can take a quick look at the Momnibus Impact Save Moms Act. So it establishes a new Centers for Medicare and Medicaid Services demonstration project to transform the way maternity care is delivered. And it creates innovative perinatal care with an alternative payment method to address clinical and non-clinical factors in payments for maternity care. And it hopes to develop strategies for creating that continuity of care. So looking at pregnancies and then up to 1 full year after postpartum. And then let's do a quick breeze through of increasing the diversity in the perinatal workforce. So more than 1/3 of US countries are maternity care deserts, with no hospitals offering obstetric care and 0 obstetric care providers. And maternity care is limited in both rural and urban communities. And even more than that, about 1 million African American women live in maternity care deserts. And so located in metropolitan or urban settings. And one solution could be to scale up and diversify the perinatal health workforce. And taking another bill from that Omnibus Act of 2021, the Perinatal Workforce Act. It is actually asking the Secretary of Health and Human Services to create a funding stream to create and scale up programs that'll grow and diversify the maternity health care workforce. And that can include people like doulas, community health workers, peer supporters for more development of the holistic healthcare system. And it can also help study the barriers that prevent women, particularly low income and minority women, from entering those maternity care professions. And that study would be that data, once again, that you can use to improve upon your outreach access and making sure that you are reaching all folks that you want to help and improve upon. Doula care, just to touch on one form of that perinatal workforce, scale up could be for doulas. So let's go into doula care. A quick benefit would be that it's evidence-based and to improving maternal and infant care. And it definitely has potential cost savings in terms of cesareans are 1/3 of all births, and the cost 50% more than vaginal births. So when you have that personalized approach with the doula, they provide support before, during, and after delivery. And that extended social support from conception through postpartum creates a stronger relationship with the patient, and it creates a deeper understanding of that birthing person's unique needs and wishes, which I noticed was another concern. So you wanted to make sure that you had a connection with your clients all the way through their care system. And so having that doula would be an excellent resource for you and your programs to tap into. But some of those barriers that may hinder you from using these doulas are that they're not currently covered by insurance. And so most doulas make a living by serving those clients that are able to pay out of pocket. But what we are looking for is that understanding that doula care is a promising approach to combating these health disparities. However, most doula programs do target under-resourced and marginalized communities of color and are funded by private foundation grants. So what we are looking for and thinking about is that funding from government and Medicaid managed care are far less common. And that's something that you may want to look into in terms of advocacy approaches. And just to quickly go through that doula, the midwives that Inas touched on earlier, making those clinical community linkages. We want to help create that holistic maternity care team because it improves outcomes for mother and their families, and it mitigates those negative experiences in the hospital setting, and it supports that health system coordination in building that continuum of care. And then lastly, just to think about discharge and follow-up during the postpartum period. How can we make this a smoother transition for our clients? You want to listen to the community that you're serving in order to appropriately address the concerns and to create that shared decision-making environment for you and your clients. And also looking at the social determinants of health. And applying and ensuring that continuity of care when you are creating that relationship and getting into their unique needs and wants. And then just to close us out, we're going to look at the advocacy efforts with a birth equity lens, possible work and policy examples that could assist you in making sure you're making the next step towards decreasing those birth inequities in your programming. And with that, I'll turn it over to Ina.
Thanks, Phoebe. I know we've got maybe about 5 minutes or so, so I am not going to belabor any points. I think Peggy's presentation really spoke to the variety of efforts that we need to be able to address these poor outcomes. And I think that talking about at all the different levels, the combination of programming that's needed really, for me, centers on a racial equity approach or birth equity lens. And just what you'll see here on the slide here is that a birth equity lens or racial equity lens values communities with the highest risk of poor outcomes. It ensures efficient use of program funds, encourages community partnerships and innovation, and makes racial equity a priority for providers. Like Peggy mentioned, training for providers being mandatory across the state. And it also centers and integrates social determinants into health systems improvements. Phoebe, let's skip the next couple of slides and I'll tell you where to stop. Keep going. Let's go to let's go down to our what is your start? Because I think Peggy really brought home a lot of the points here. What we talk about there is just really a couple different strategies. But really what it comes down to is thinking about what are the logical steps for your program, right? What are the funding dollars that you all are bringing in? Do you have additional funding? Do you have the staffing structure right now that's necessary to begin some of these smaller actions? So we just brought back up the social ecological model here, again, just because I know that a lot of what we focus on is at the individual level, but just bringing it out just another layer up, right? I'm sure lots of you are doing home visiting. What are the other community partnerships that you have in place? What beyond that are you also seeking? Are you applying for additional funding? What are the policies locally? I know Phoebe talked about federally, what are some of the policy changes that are happening or that are being advocated for? But what are the changes locally that you can advocate for your program? And so I guess the good thing about this session is that this is part 2. We have part 3, which is really going to be getting into strategies and kind of walking you through kind of the answers to these questions. But in between now and our next session, which I believe is mid-August, I would like for you all, proposing for you all to begin thinking about concretely about who are your partners, who are partners who you might not have leveraged yet, who might be able to help you get some action on some of these policies. What are the changes that need to be made? Have you conducted any surveys with your participants, right? What is the status of data that you have? Are we hearing a lot of our information anecdotally? Do we have any other additional information, any other additional data that we can use in submitting our grant proposals and applying for additional funding? And thinking about also, what's your sphere of influence, right? What is your partner's sphere of influences, right? And how do you combine those two so that you're able to improve your 4th trimester outcomes? So I'll leave that, and we can just leave this slide up for us to kind of just think about as we move into our question and answers. I will turn it over to Olivia or Elisa, just to make sure that we've got a few minutes for questions. Thank you all so much for your attention.
Thank you so much, and awesome, Phoebe, and thank you, Peggy. This has been a wonderful presentation. We do have about 6 minutes left for questions. If anyone wants to chat into the chat box, or we're a pretty small group, so you can come off mute to ask your question. And then we'll just reserve the last 2 minutes to launch our satisfaction survey. So please be sure to stick around for that. So feel free to ask your questions in the chat or come off mute.
I knew it. Peggy answered all the questions with her fantastic presentation. Yes, again, Peggy, thank you so much. Presentation was very, very insightful.
Yes,
What's happening on the
definitely.
ground. Yeah.
Well, thank you. Let me just say too, if anybody wanted to have any of the resources or tools that I mentioned, just reach out to me. You know where I am.
All right, if there are no questions, we'll go through our closing slides, but again, feel free to chat anything into the chat box. So we're going to launch our short poll. It's about 5 or 6 questions. It should pop up on your screen. So if you could take the next couple of minutes to complete this. This feedback is really helpful and will help inform the next webinar in August. All right, and while everyone's wrapping that up, we can go to the next slide. So just want to remind everyone again that the final webinar in this series will be held on August 17th from 2:30 to 4 p.m. Eastern Time. We'll be sending out information about registering for that webinar through our weekly updates. If you aren't signed up to receive those updates, please email healthystart@nhq.org and we can sign you up. And then the registration link is also on the EPIC website. So thank you again so much to our speakers and to everyone for participating. We're really looking forward to the next webinar, and thank you again for joining us. If you've already taken the survey, looks like almost everyone has, you can go ahead and sign off. If you haven't, please just take a few more minutes to complete that. Thank you.
Thank you, everyone.
Yes, thank you so much.
All right, actually looks like everyone completed it. So we will sign off now. Thanks, everyone.